This is a case of a phacomorphic glaucoma. I'd like to share with you what are the important considerations whilst operating on a patient with a phacomorphic glaucoma. In the second half of the surgery, I'd like you to notice how during irrigation aspiration, I've had a massive D-strip, most likely as a result of some amount of limited visibility, and how this D-strip was surgically managed in a staged procedure. We move to understanding what are the various factors in the preoperative workup of patients with a phacomorphic glaucoma. Now, to start with, we do understand that a patient who presents to us with phacomorphic glaucoma is an emergency. We are not going to be able to sustain a reduction in the intraocular pressure until the nucleus has been removed. So we work up the patient quickly, ensure that all his systemic investigations and parameters are within their normal limits, get a physician fitness for surgery, and with respect to the preoperative workup, a biometry might be rather challenging. An optical biometry is almost certainly not going to work because you've got an intermittent, mature total cataract. Now, as a result of the associated corneal edema, it's going to be fairly difficult to attain accurate keratometric values required for the IOL power calculation. So sometimes what I do is, if there is a significant corneal edema, which there almost always is, I would give the patient a preoperative mannitol after admitting the patient, bring the pressures down temporarily. This should alleviate some amount of the corneal edema, which helps me then get a better keratometric reading, which then allows for a more optimal IOL power calculation. Now, if I'm unable to get reliable keratometric readings and the patient gives me a history that his eyes have been completely normal in the past, that he's not had any significant refractive error in the past for distance, nor has there been a significant difference in the refractive status of both his eyes, I might take the keratometric values from the other eye to do the IOL power calculation. At all points when we counsel the patient, we let them know that as a result of the corneal edema, that in cases like this, sometimes it is a little difficult to predict what the exact IOL power should be, thereby resulting in a residual refractive error necessitating glasses in the postoperative period, and this should be explained clearly to the patient. I'd like to now discuss what are the intraoperative considerations. 1. These are painful, sensitive eyes, and therefore I choose to always give them a good peribulbar block. Preoperatively, I must mention that we must give preoperative mannitol at least an hour or an hour and a half prior to surgery, so that now a reduction in the intraocular pressure thus attained would help us reduce the corneal edema and aid your visibility during the entire surgical procedure. Moreover, by also shrinking the vitreous, we now have some more space in the anterior chamber to manipulate our instruments and the nucleus. Next, let's understand what's going on in the anterior chamber. Now, when a patient has a phacomorphic glaucoma, 1, he will have a mid-dilated pupil. Often as a result of the inflammation, it might be bogged down to the anterior capsule. The patient is likely to have a pupillary block as well as a very shallow anterior chamber in the periphery. Now, as a result of the shallowing of the anterior chamber in the periphery, you're likely to have difficulty in getting the instruments in and out of the eye, and we've got to be extremely cautious that we don't end up damaging the corneal endothelium while negotiating our instruments in and out of the eye. We need to then consider that we're going to be working with a small pupil. We may need to break down some of the posterior synechiae and are very likely to require a pupillary dilating device, be it hooks or a ring, in order to attain adequate visibility to be able to then proceed with the rest of the procedure. Finally, a decision needs to be taken whether you're going to perform a phacoemulsification or a manual small incision cataract surgery. Now, if I have adequate visibility, if I have controlled intraocular pressures, and if I have a pupil that I believe I can comfortably perform a phaco through with or without the aid of a dilating device, my first choice would be phacoemulsification in these cases. The main reason for choosing a phacoemulsification here is that I'm not exposing the anterior chamber to the atmospheric pressure because I'm working in a closed system. In a SICS, when you're removing the nucleus, there's an increased chance, I would think, of having an expulsive choroidal hemorrhage. Let's now move to watching the surgical procedure. Now, this patient presented to the outpatient department with a history of headache, redness, pain, watering, and a loss of vision. On examination, he had a classic phacomorphic glaucoma, pressures over 25 or 30 millimeters of mercury, some corneal edema, a mid-dilated pupil, and a mature cataract. We start with making the incisions. Whilst creating the incisions, we need to be mindful of two things. One, the associated corneal edema may make the creation of the incisions slightly difficult because of limited visibility. Equally important is the fact that the peripheral anterior chamber in these cases is rather shallow, so the chances of damaging either the peripheral iris or the corneal endothelium while creating either the 2.8 or the side port incision are significantly high. So we must exert adequate caution whilst doing so. Adequate staining of the anterior capsule is extremely important because of the associated lack of visibility that comes in these cases. Staining of the anterior capsule of this mature cataract should be done giving adequate time for the stain to take on. Sometimes in a phacomorphic glaucoma, the space available to actually put in air and then inject dye under it may be extremely limited. A cohesive viscoelastic is then introduced into the anterior chamber. All the excessive air bubbles are removed by pressing on the posterior lip of the limbus. This allows for maintaining adequate space to work in this extremely shallow anterior chamber. Moreover, is useful in performing orexis in an intumescent cataract. As you can see, I then introduce two Y-shaped hooks through the side port incisions and attempt to create a pupillary stretch. As you can see, at the end of the pupillary stretch in two directions, I have a fairly large pupil. We then proceed to performing the capsular rhexis. Now, in an intumescent cataract, I like to do a double rhexis, wherein I generally create a small rhexis, wash out the intumescent fluid, reduce the intralenticular pressure, and then proceed to creating the second rhexis. This is what you'll see in this part of the video. After creating a nick in the smaller rhexis, in order to enlarge it, I need to introduce a pair of intraocular forceps. Now remember that what's different in this case is the fact that your working space is less, coupled with limited visibility. This may be a slightly challenging maneuver. Make sure that you do not endanger the corneal endothelium whilst doing this step. As you can see, we've now successfully completed the rhexis, and we have a rhexis that is comfortably sized to allow for ease of phacoemulsification. After decompressing the globe a little to remove some viscoelastic, I perform a gentle hydrodissection. Not too much, because I actually have an intumescent cataract and I know this nucleus is likely to turn quite easily. We then introduce a dispersive viscoelastic into the anterior chamber, which serves to protect the corneal endothelium during the phacoemulsification procedure. It's important to use a dispersive viscoelastic because you've got a cornea that's anyway compromised. We now proceed with phacoemulsification using the direct chop technique. I like the Kelman mini flare tip. I like the downward angulation that comes about 22 degrees, which very naturally places the tip at a slightly downward position. The settings that I use are a power of about 30 to 35%, a vacuum of 350 millimeters of mercury, and a flow rate of 35 to 40 cc per minute. The technique being followed is the direct chop technique, where the nucleus is impaled by the phacoprobe. It is chopped into two heminuclei, following which each heminucleus is further subdivided into smaller emulsifiable fragments, after which each and every one of these fragments is emulsified. What's different in these cases is the fact that you're working within a very shallow anterior chamber and looking at emulsifying a very large, thick, intumescent nucleus. It's very important to intermittently stop and replenish the viscoelastic into the anterior chamber with a view of protecting the corneal endothelium from significant damage. As the second instrument is being withdrawn to perform a viscofluid exchange, there seems to be a tendency to an iris prolapse. The iris that is prolapsing is very gently repositioned as shown. The surgeon then continues with the phacoemulsification procedure. In the manner demonstrated here, the nucleus is downsized and each of the fragments are emulsified in the phacosafe zone, that is, in the pupillary plane. At the end of nucleus emulsification, the instruments are removed from the eye and then we proceed with the bimanual irrigation aspiration. The biggest advantage of a bimanual irrigation aspiration is that the hands can be swapped and the aspiration can be reintroduced from the other side. In this way, we are able to achieve a circumferential removal of the cortex. Unfortunately, let's see what happens here. The surgeon accidentally holds on to the desmids and rips it all across its entirety accidentally. Upon realizing this, the aspiration is stopped, the desmids left in its place, and both the instruments removed. Let's watch this in slow motion again. Watch how the aspiration cannula grasps hold of the temporal half of the desmids and strips it almost entirely all the way to the nasal end. As you will now see, we are left with a subtotally detached desmids membrane, which is now shriveled up upon itself, floating in the anterior chamber. I now introduce a little viscoelastic, move the desmids slightly on the side, and then implant a single-piece monofocal IOL carefully in the capsular bag. Following the successful implantation of the IOL within the capsular bag, a very gentle visco wash is performed without disturbing the desmids membrane, which lies quite close to the corneal endothelium. Upon the completion of the visco wash, both the instruments are removed from the eye. You will now see a few maneuvers that are performed which aim at trying to open up the desmids to get it to lie against the underlying stroma. These maneuvers include either tapping on the surface of the cornea, either over its center or somewhere towards the periphery, as well as injecting tiny aliquots of fluid through either side port into the anterior chamber, both of which would aim at opening up the desmids to get it to lie against the stroma. Several attempts were made to try and unfurl the desmid scroll. The surgeon then finally injects a little air under the desmids membrane and fills up the anterior chamber. With the help of gentle manipulations over the surface, the surgeon is actually able to then open up the desmid scroll and flatten it against the underlying stroma. This desmidopexy is further augmented by introduction of some more air with the help of a 30-gauge cannula connected to an air-filled syringe to tighten the airfill in the anterior chamber. A few minutes later, this is the kind of corneal clearing that we did see. This brought us to the end of the surgery. However, on day 1 post-operatively, this is what we saw. The patient had a vision of just counting fingers close to face and a diffuse corneal edema corresponding to the area of the detached Descemet's membrane. An anterior chamber OCT was then performed, which revealed the presence of the complete detachment of the same Descemet's membrane. We then decided to perform a pneumatic descemetopexy the next day. This part of the video is rather long. I've edited it just a little so that you can actually understand the time it takes for the cornea to clear. To start with, I make 4 or 5 venting incisions with the help of a 23 gauge MVR in the parapupillary area. This helps the fluid that's accumulated between the descemet's and the underlying stroma to find a way out when you perform a pneumatic descemetopexy. Let's now see how the venting incisions are created. In this particular case, I use a 15-degree lance tip to make the venting incisions. These are full thickness incisions that are made into the cornea in the parapupillary area. This is followed by the pneumatic descemetopexy. I leave the cannula attached to the air-filled syringe within the anterior chamber. I intermittently keep injecting more and more air into the anterior chamber. Whilst maintaining the cannula in the anterior chamber, with the help of a cotton bud, I keep wiping off the fluid that keeps coming out of the venting incisions. This is what you will see in this part of the video. I keep intermittently injecting some more air into the anterior chamber, and note how bubbles of liquid are seen in the venting incisions, which are then subsequently wiped with the cotton bud. This procedure of intermittently injecting air into the anterior chamber is repeated until a point when no fluid appears at the venting incisions. In order to aid the extrusion of the fluid from the venting incisions, sometimes, as you can see, I use the McPherson's to press and splay open the openings of the venting incisions. Note how slowly but surely the cornea starts to clear as the descemet starts to get reattached. The corneal epithelium may be debrided with a view of enhancing visibility. Without the presence of an intraoperative ASOCT, it might be difficult to ascertain whether the Descemet's membrane is truly attached or not. Now, how do we ascertain that the Descemet's is attached? Now, the two factors that make us believe that Descemet's is attached is one, the cornea clears. You can see where we began and where we are now. And second, upon pressing on the venting incisions, you will not find any more fluid coming out through these incisions. Over a few more minutes, we found a further clearing of the cornea. As the endothelial cells on the reattached Descemet's start to function, watch how the cornea clears even more. At the end of the surgery, this is the end result that we achieved. As a last step, we just confirmed that there is no fluid coming out of the venting incisions. This now brings us to the end of the case. On table, what appears to be a completely reattached Descemet's membrane. Let's just compare now what it looked like before and after. This is at the beginning of the surgery with a completely opaque cornea, and this is the surgical end result. Few hours after surgery, this is what the cornea looked like. And a post-operative OCT performed on the next day revealed a completely reattached Descemet's membrane. The interesting thing about surgery is that no next case is likely to be exactly like the previous one or like the previous thousands that you might have performed. We need to be mindful of all the challenges that we may face during the surgery. A phacomorphic glaucoma comes with its own set of challenges. All the considerations in dealing with a case like this have been discussed at the beginning of the surgery. However, if you find yourself facing a challenge or have created some kind of complication, it's important that we own our complications. Ensure that you build yourself the skill set required to deal with the complications, and if you are not equipped with dealing with them at any stage of your surgical career, seek the timely help. Do not wait, procrastinate, and wonder whether things are going to get better. And finally, dealing with the Descemet strip is one of the biggest challenges that I've had to face in my surgical career. I make sure that I take my time to understand what exactly is the configuration of the Descemet strip. I'm always there when an anterior chamber OCT is being performed to understand the exact extent, location, and the position of the Descemet strip. And finally, after carefully counseling the patient to understand exactly what's going on and reassuring him, I take him up to settle it at the next surgery. With this, I come to the end of the video tutorial. I do truly hope that you found it useful. Thank you.